Welcome to your online lecture for neuromuscular electrical stimulation. Today we are going to talk about a different form of stim that is used to help facilitate muscular contractions in patients who have atrophy, disuse atrophy, or for whatever reason just can't create a muscular contraction without assistance, right? From early on, we've talked about the following modalities. We've talked about IFC, we've talked about pre-mod, and we've talked about TINS. And all three of those modalities are pain modulating modalities, typically aren't used to stimulate or increase strength in a particular muscle group. The modalities that we're going to talk about today are modalities that are specifically used in muscle re-education. So our post-op patient, that patient that might have been in a walking boot way too long and now has an atrophied calf, and just can't produce the force that they normally would have produced pre-injured state, right? The key term here is going to be that the type of electrical stimulation that we're referring to facilitates muscular contraction. It does not in any way replace our normal physiological muscle contractions. And here's why. When we think about muscle contractions, in general, we know that electrically stimulated muscle contractions and physiologically created muscular contractions are pretty similar, but they vary in one key difference. And that difference is the order in which muscles are actually recruited, or muscle units are recruited. So when we think about electrical stimulation, it's going to recruit the largest type 2 diameter muscles first. So it's going to recruit those large diameter muscle fibers first. And then finally, it will recruit the smaller axon muscles next. What we know about larger type 2 muscles is that they fatigue quicker. And so we can see that already we're seeing a very big difference. We're recruiting the faster fatiguing motor units first, which means patients who use this stimulation are going to fatigue a lot sooner than those who would be performing a natural physiological muscle contraction. In a natural physiological muscle contraction, the smaller diameter type 1 slow muscles are going to be recruited, and they are slower to fatigue, right? So they take a lot longer to fatigue, which is why it takes us a lot longer to fatigue when we're performing muscle contractions, right? So to repeat, because I know I'm talking fast, forgive me, electrical stimulated muscle contractions, they recruit the larger type 2 fast twitch muscles first, which means our patients will fatigue a lot quicker with our electrically stimulated muscular induced contractions. This is the biggest differential between a muscle contraction that's elicited through electrical stimulation and that in which the patient physiologically produces on by him or herself, okay? That is the key difference and something that we have to keep in mind when we're setting up our parameters. So if the goal of our treatment is to muscle re-educate or to increase strength within a particular muscle group, then we have to take into account the overload principle. Well, we know, and what's always said about the overload principle is that the greater the load placed on the muscle and the higher the force of the contraction, the more strength that we're going to see in terms of gains over time, right? In electrical stimulation or neuromuscular electrical stimulation, that force that we're talking about is most often created by the amount of current or the amplitude of the current being applied to that particular patient. So it's going to be important when you're thinking about this that we have to increase the amplitude such that we at least get to a motor response where we're actually seeing that muscle contract, right? Because if we don't have enough force, then we're not going to see strength gains in our patient. So this is the time where I say to you guys, when we do muscle re-education, when we're using electrical stimulation with the goal to muscularly re-educate, it's going to be painful. It isn't going to be something that's extremely comfortable for that particular patient because we need enough force to cause strength gains, right? So again, keep in mind that neuromuscular electrical stimulation is limited by patient tolerance and fatigue. Because if we go back to this slide here, remember we said we're recruiting those larger fast twitch type 2 muscles. And so when that happens, they fatigue a lot sooner. So just keep that in mind as we progress through these next few slides. So there are two types of electrical stimulation that most often are used for muscle re-education. There's one more, and we'll talk about it a little bit later in its own online lecture. But the first of them is the Russian protocol. It was probably one of the very first muscular re-education electrical stimulations that we've seen. We most often see it in those late night infomercials. So this is the protocol that we see most often. In terms of the wave form, it is an alternating current, but it certainly can vary. So you can have square types, triangular types. You get to determine that based on the device that you actually that you purchase. It was developed by Kotz, and his intent was to actually use electrical stimulation to not facilitate muscle reeducation, but to increase strength in his Russian athletes. So he was using it for a completely independent reason than we would be using it as clinicians, right? Most often, if we have healthy athletes, we want to see their strength gains occur naturally. But for Kotz, when he was training, he wanted as quick as is possible, I want the strength gains. And so he used Russian electrical stimulation to do that. What we know about Russian stimulation is it uses a medium frequency at about 2,500 hertz. Again, it's an alternating current. And the cool thing is kind of like another modality we'll talk about, high volt, is it's delivered in bursts. And so you get a little bit of an off time to kind of negate that median frequency that you see here. But one of the cool things is because it's at a medium frequency, it's going to encounter less tissue resistance. And so it can actually travel down to the target tissue, which in this case is going to be muscle, and it's going to trigger that contraction, right? And so this is an important concept with Russian. It's an alternating current, okay? The next current that we have that has also been used in muscle reeducation is biphasic. And as the name implies, it's a biphasic waveform. One of the cool things about the biphasic form of muscle reeducation is that it can be symmetrical or asymmetrical. So if it's symmetrical, that means that the charge is most opposite going to be what? Is going to be zero, right? Because it's going to go equally up on that isoelectric line and equally down on that isoelectric line. So essentially it's going to result in a zero net charge, zero polarity whatsoever. What we know about biphasic when compared to Russian is that it's a more comfortable waveform. And so it tends to be the electrical modality that we use early on in the muscle re-education phase when we're trying to muscular re-educate. And eventually, like when we get to the end phase of proliferation or the maturation phase, then we progress to the Russian waveform. So I guess what I'm saying here is clinical use here. Biphasic waveform is by far more comfortable in terms of muscle re-education, and Russian is a little bit more uncomfortable. It has to do with the fact that Russian is delivered in those burst packets. And so those bursts tend to be a little bit more intense for the patient. So if I'm you, I start thinking, okay, in the acute phase, I'm probably going to use biphasic. It's extremely comfortable. It's capable of muscle re-educating, but it's comfortable for the patient. And remember, we said it's already going to be uncomfortable because we have to crank up the amplitude of that treatment to at least get a motor response. So why not make sure that that patient is using a comfortable waveform? So early on, acute phase, we want biphasic. And then as they progress through the proliferation phase and maturation phase, most often we'll switch over to Russian, which is a little bit more uncomfortable in terms of its waveform and the way the actual stimulation feels. So if you're in lab, I encourage you to try the two different waveforms so you can see for yourself how they actually feel when you're at the motor level. Okay, so biphasic, you can have symmetrical, which is to me is intuitive. And then you can have asymmetrical. So that asymmetrical could be balanced. And so an example would be you could have a square and then a round, but they're balanced. They go up and down the same. You can also have an unbalanced waveform. So you could have like a triangle waveform that goes up 5 seconds maybe, and then you could have a triangle that goes down 10 seconds. So the charge in the phases is not equal. And so what that means is you're actually going to create a polarity, either negative and or positive, which when we get to high volt, you'll understand why that polarity is extremely important. Most often though, our biphasic machines are typically symmetrical or asymmetrical balance, which means you still get no net charge whatsoever. The beautiful thing about biphasic again is that it's extremely comfortable with larger muscles, specifically when it's symmetrical. And then one cool thing that we're learning over time is that the asymmetrical balance actually tends to show that it's more comfortable with the smaller muscles. And I imagine that you probably have less of the waveform coming at the muscle group. And so as a result, that smaller muscle is able to withstand the forces that are coming at it. So parameters, electrode placement is going to be huge and key. It's kind of like IFC. If you don't cross the wires in IFC, then you're not doing a really good treatment. So with muscle reeducation, you have to make sure that you have one electrode over a motor point, over that muscle's motor point, right? If you don't have one electrode over the motor point, then you're not going to stimulate or recruit motor units, right? So what we know about the motor point is it's the place where the electrical stimulus will produce the greatest amount of contraction with the least amount of electricity, right? So if we have it right over that motor point and we have less electricity needing to be delivered, guess what? That makes the treatment more comfortable for your patient, right? So we want to make sure that it's in the middle of that muscle belly. The other place, you could place it either proximal or distal to the muscle, but the biggest key component is making sure you have one electrode over the motor point. In terms of arrangement, you want to make sure that other electrode, if it's a bipolar setup, is parallel to the muscle fibers, right? Not perpendicular. And you want to make sure that they're at least 2 inches apart. So if you put them too close together, that really goes back to how deep the electrical stimulation can travel, right? If they're too close together, it's going to be superficial and it's not going to recruit motor units. And if they're further apart, then we know that it travels deeper. So we're at a higher risk or rate of collecting or recruiting motor units. So pad placement is extremely important over the motor unit and parallel to the direction of the muscle fibers. What does that mean, you guys? It means that you have to know your anatomy, right? Now, the trigger point or motor point part, not so much. I don't have that memorized. So what I'll do in the clinical setting is put the pad where I think the motor point is, and then I'll turn up the amplitude. And if I get a contraction, then I know that I've hit it, right? If I don't get a contraction or a satisfactory contraction of that muscle group, then I'm going to turn off the electrical stimulation and move my pad around. Now, some of us walk around with books or some clinics will have the motor point map posted, but if they don't, then you just do your best by placing it somewhere you think it is, turning the stim on and seeing if you get the contraction. If you don't, try again, right? You can kind of start talking to your patient. They'll never know what you're doing. Just play it off. Show confidence and play it off. Okay, so there's 2 waveforms. We have the pulse biphasic, which I said is more comfortable of the 2. In particular, the symmetrical biphasic is really good for the larger muscle groups, and the asymmetrical balance is better for the small muscle groups. We should really start with biphasic in the acute phase because it's the more comfortable waveform. And then you have the Russian protocol, which delivers a higher treatment voltage, is a little bit more uncomfortable. And so in my mind, this is a modality for muscle reeducation that should be used in the later proliferation maturation phases. But what we do know is that because it was developed to see fast strength gains, that you're going to see greater and faster strength gains with the Russian protocol. Just be mindful in the acute phase, it's probably the worst modality to use for muscle reeducation because it will be extremely uncomfortable. And part of what we do as clinicians isn't about quick, fast, and in a hurry, right? We want to make sure our patient is comfortable with what we're doing first. And so we start with biphasic and progress them to Russian protocol. And some of your check marks would be, can the patient produce a contraction? Is there pain with contraction, right? These are things that you want to be asking yourself as you decide, should I move from biphasic to Russian and or not? The other part that becomes important to adjust is the pulse and or phase duration. It depends on the device, which is why you see pulse here. Some of you are going to be like, Dr. Cosby, it's the phase. In some devices, it will be. But ultimately, what we want to do is we want to adjust this, right? Remember, it has to be at least 150 microseconds, if not larger, to cause the depolarization of the motor units, right? And on these 2 devices, we can absolutely adjust the phase or pulse duration depending on the device, right? Remember, we want shorter phase or pulse durations for smaller muscles, okay? We want longer phase duration, pulse duration for larger muscles. Does that make sense, you guys? Good. I'm hoping so. I'm hoping that you're actually tracking with me. One thing that I kind of want to end this slide on is to make sure that we're on the same page with this, that your shorter phase durations are going to require more amplitude. So remember that chart in the initial principles of electricity where we said longer durations require less amplitude, but shorter phase duration or smaller muscles are going to require more amplitude to achieve the same strength of contraction, right? But if we just look at this from a clinical perspective, as long as we're getting that motor response in that group, then we will be fine. We will see strength gains as well. In terms of parameters, so frequency is important. And so I say greater than 30 pulses per second will produce, less than 30 pulses per second will produce separate muscle contractions. So what we need is something more frequent, more fast, because essentially what we want to create is tetany, right? So the ideal would be anything between 35 and 50 pulses per second. So we're talking frequency right now. And then you could go up to 80 pulses per second if needed for patient comfort. But the ideal would be probably 50. We know at about 50 is that the patient's muscles reach tetany, which is what we want. We want the muscles to reach tetany. If they reach tetany, then we know that that muscle is in a state of hypercontraction. And so we're going to start to see strength gains occur over time. Increased frequency between about 50 and 80 may produce greater muscle strength. But here's the thing, when you go over 80, we start to see more rapid fatigue of the patient. And it has to do with the order of recruitment, right, guys? So remember, the type 2 fast twitch, quicker fatiguing muscles are always recruited first in a neuromuscular electrical stimulation. So when we increase the frequency outside of the recommended 35 to 50, we increase the risk for patient fatigue. So as long as you're keeping that in mind when you're setting up your patient, then you'll be fine in your treatment. Okay, the next parameter that we have to talk about is the duty cycle. We talked about duty cycle in ultrasound, and now we're talking about it here. It's the amount of on and off time. So we set this to allow the muscle to relax, right? To allow the muscle time to recover after a contraction, right? And this duty cycle is going to change depending on the phase of healing, depending on your patient, right? We use it most often to limit the amount of fatigue that patient's going to experience because the order of recruitment is reversed. And so in terms of recommended on time, between 6 to 10 seconds, most clinicians are going to have that machine on for 10 seconds most often, but you notice not outside of that, right? And in terms of recommended off time, it's going to vary, but can I just give you maybe an equation to help you with mathematically? Typically what we want to start with is something that's 1 to 5, right? So if it's on for 10 seconds, it's off for 50 seconds, right? If we think about it from a 1 to 5 ratio, then we'll never cause an increased amount of fatigue for this patient. Now that on-off time is going to vary and is going to change depending on where your patient is in the healing process, right? And I think the next slide will get us there. So this is going to decrease as the patient progresses, right? So we'll start at 1 to 5, but essentially like when they get to the proliferation phase, they might go down 1 to 3. And then as they progress to the maturation phase, maybe it's 1 to 2, right? And so for muscle reeducation, this is the protocol that we follow. If we want to reduce spasms, then the recommended duty cycle is 1 to 1. So 10 seconds on, 10 seconds off, because we actually want to fatigue the motor unit, right? We want the motor unit to quiet down and to stop contracting, right? If we want to pump edema out and facilitate the lymph system, then again, remember that we want to have that 1 to 1 ratio. So with ramp time, remember ramp is slowly ramping up the frequency and then ramping it down. So what we see is there's this increase and or decrease in the amount of force being applied versus just shocking our patient. The recommended time is about between 1 to 4 seconds for the ramp time. You'll have to play with that a little bit. It wasn't something that I altered very often, but between 1 to 4 seconds. What we see in the acute phase is we want more time for the frequency to ramp up, so we'll use that 4-second span. But by the time they get to proliferation and maturation, shouldn't need more than a second or two to ramp to peak frequency, right? So again, you have to think about phases of healing here. Okay, the current amplitude, or what the patient actually feels, most often known as intensity, is going to be adjusted according to the strength of the muscular contraction desired. So most often, again, if we get to just the motor level response, so we crank it up until we see motor response, I think that's pretty good. But the ideal would be our goal to set our goals, right? What do we want ultimately for our injured limb to be by the time we finish the acute phase? Is it 10% of the maximum voluntary isometric contraction? Is it 20% compared to the uninjured limb, right? So we have to ask ourselves, what are our goals in each of the phases of healing? And that will help us determine what our amplitude should be. But if nothing else, you guys, your amplitude should be such that at least a motor contraction is elicited. You should see a muscle contraction. If you are not seeing a muscle contraction, then you are not doing muscle reeducation correctly. And again, this is going to be painful. So keep that in mind. Warn your patient. To reduce muscle spasms only enough to produce visible muscle contraction. So if the goal is to reduce a muscle spasm, you just need a very small but visible muscle contraction. Most often that is enough to cause a reduction in muscle spasm. Again, the caveat is you have to be over the motor point of that particular muscle. In terms of treatment times, it's going to vary. I don't really think of muscle reeducation as a treatment time. I think of it as a goal to get to a certain number of contractions. So most often in the acute phase, we start with about 10. We give the patient, can they get through 10 contractions? 10 seconds on, 50 seconds off. Can they get through 10, right? Then in the proliferation phase, can they get through 15? Then in the maturation phase, can they get through 20 contractions, right? The treatment time, I guess what I'm saying, is going to vary. It's going to vary based on duty cycles. It's going to vary based on whether or not your patient fatigues. So you can set a 5-minute treatment time, but if your patient fatigues at minute 3, then you stop that treatment, right? So I personally would just use total number of contractions to drive my overall treatment for muscle reeducation, which is kind of counterintuitive, right? In what we do as clinicians, everything's time. But in this particular instance, when we're talking muscle re-ed, I really encourage you to not think about it from a time perspective, but a contraction perspective. And what this does is it drives patient goals. So day 1, the patient can only do 5 contractions. We celebrate that. Day 2, they can do 7. Day 3, they can do 10. And now they start to see their own progress, right, you guys? So these are things to just think about as you move away from becoming knobologist and you become a true clinician who's capable of using electrical modalities to physiologically improve patient outcomes. That is the end of our muscle reeducation unit. I want to encourage you guys by saying, I know that many of you may not have the opportunity to decide parameters, but if nothing else, each of your clinical sites has different electrical stimulation units. Look at what they have in terms of muscle reeducation. Do they have biphasic? Do they have Russian? We're going to talk about high volt next. Do they have high volt? Look at whether or not you can adjust the phase or pulse duration. Look at whether or not you can adjust the ramp, right? And think about all these things. One last thing that I want to say is that using electrical stimulation for muscle reeducation is a really positive thing to do early on in the injury, right? But as that patient becomes more functional, then we should be doing more functional-like activities. So I am in no way saying that neuromuscular electrical stimulation should replace all of the functional activities that you should do. No, it facilitates, it helps the patient learn how to contract. Once they learn how to contract, would it be unreasonable to still put the stim on, but maybe have them do lunges while the stim is on in the on time and have them relax? Would it be reasonable to have them do squats while the stim is on and then have them come up from that squat when the stim is off? Heck yes, right? So you can do this thing called functional electrical stimulation, which certainly still facilitates the muscle contraction, but does so in a functional environment, right? We start less functional because they're in the acute phase, but as they progress and as they move and as they gain the ability to physiologically contract, then we still use neuromuscular electrical stimulation, but we move it from a less functional position to a more functional position. Okay, hope you learned lots. Can't wait to see you. Have a wonderful week.